This is my answer to the case 4 question. The first question is, this case looks like a colloid cyst. What's the result of the cytology? The cytology result was benign. In this patient, after the fluid was removed, the lesion was collapsed, and the solid part, which was pressed by the fluid, was seen. It was diagnosed as benign by FNA at the solid part. The second question is, do aspirates from the cystic nodule send liquid cytology like that with very little solidity? As I mentioned earlier, this lesion was not a complete cyst but a predominantly cystic nodule. In my hospital, we usually do conventional smears with 2 slides and send the rest of the samples with liquid cytology. In the case of an exceptionally complete cyst, it can only be removed. Whether it is a complete cyst or not can be determined after removing the fluid. Like this case, it is common for solid components that have been pressed by the pressure of water to be seen after removing fluid. The third question is, sometimes like this case, I had experiences that the cystologic result was non-diagnostic. In this case, do you consider it a benign nodule? FNA is a screening test. The final diagnosis of the nodule is surgery. However, thyroid nodules are too common in adults, so it is not appropriate to operate on all the nodules for a 100% diagnosis. Therefore, the nodules that are highly likely to be a clinically significant cancer or those that are less likely but larger in size are subject to surgery. The 2023 Bethesda system showed that the cancer chance is about 5% to 20% at non-diagnostic nodule. This study from my hospital was published in Radiology in 2015, and it was selected by This Month in Radiology. This study used quark thyroids. The thyroids is considered to be category 3 if there is no suspicious feature among the 5 suspicious ones. Category 4A is 1, category 4B is 2, category 4C is 3 or 4. If there are all 5, it is judged as category 5. As you can see, if there was no suspicious feature, the cancer probability was less than 2%. And except category 5, the cancer probability was all less than 4%. Therefore, considering the ultrasound findings together with the cytologic result can help more in managing the patient's management. The fourth question is, in this case, I think it can be recurred well. What do you do when it recurs? The probability of recurrence after simple aspiration of the nodule has been reported to be 60% to 80%. As far as I know, there are no findings predicting recurrence. In the case of recurrence, the patient's symptoms are important for the management of the nodules. If there is a high probability of benign, I usually recommend follow-up if the patient has no symptoms, even if the fluid is filled up again. If the patient is quite uncomfortable due to the nodule, I consider ethanol ablation after removing the fluid. When the nodule is a predominantly solid one, RF ablation can be a better choice. Thank you.